Dear participants of the forum, on behalf of Roche, it is my pleasure to welcome you in the Satellite Symposia. Today, our presenter will be Professor Marius Žemaitis, who is a head of chest oncology and interventional pulmonology center department at Kaunas clinics, Lithuanian University of Health Hospital Sciences. And he will give you a lecture today about comprehensive genomic profiling in oncology and the benefits for clinicians and patients. So please, Professor Žemaitis, the stage is yours. Professor,
hello everyone. Can you see my presentation?
Not yet. Yes, now we do. Now we do. All good. And we hear you as well.
Thank you very much for a very nice introduction. And it's a great pleasure for me to present this topic of comprehensive genomic profiling in cancer, benefit for clinicians and patients. I am not a biologist, and I present my point of view as clinicians to this very important topic. And as you know, the life of clinicians before the era of molecular biology was very simple. And as you can see here, for example, the treatment of lung cancer was very simple as well, because it was only chemotherapy, and depending on the performance status, combination of chemotherapy or monotherapy. And it was changed in 2004 when it was discovered a EGFR mutation and a small molecules, and these molecules were very active in these cases with EGFR mutation. And now we have a lot of phase 3 clinical trials which show that targeted therapy were very effective regarding response rate, regarding progression-free survival in these patients with some EGFR mutations. Another molecular target was ALK translocations, and nowadays we have a lot of as well phase 3 clinical trials which show that these new targeted therapies is very effective as well. So, and this is evolution of non-small cell lung cancer treatment. As already mentioned, in 1990s, it was only platinum-based chemotherapy. And after that, we have introduction of biological treatments with targeted therapy, and nowadays the immunotherapy. And you know, the immunotherapy is like revolutionary therapy nowadays in the treatment of cancers, and for example, lung cancer. And the question is immunotherapy nowadays the best option in all cases for lung cancer treatment? Maybe we just need to investigate the immunological markers like PD-L1, and that's enough. And if we look for the treatment algorithms for cancers, and here is example for non-small cell lung cancer, advanced non-small cell lung cancer, we see that in the first place is molecular testing. And if we have this molecular test positive, then in the first place should be targeted therapy. And only in cases when molecular tests are negative or unknown, we should look for possibility of immunotherapy. And the reason for this is because there is increased risk of immune-related toxicity for sequential use of immune checkpoint inhibitors followed by TKI. And another reason is that mutations and translocations are associated with lack of benefit to immunotherapy. And as you can see here from phase 3 clinical trials in second line and as well as in first line. So how many drivers, targetable molecular alterations could be detected in lung cancers? We already spoke about 2 of them, EGFR mutation, ALK translocation, for example. And if we looked at these pies, you can see that our understanding of the genomic landscape of cancer continues to expand. And if we in 2004, we known only 2 mutations, EGFR mutation and KRAS mutation. Then in 2020, there is a lot of mutations, a lot of molecular alterations, and unknown situation is only in small minority of cases. And this development of multiple targeted therapies has revolutionized the treatment landscape in advanced cancer. And example here is, again, lung cancer. As you can see, a lot of molecular alterations, and there is already approved many targeted therapies for these alterations. The next question is, which molecular alterations should we test it in lung cancer? Because you've already seen that there's a lot of these alterations. And here there is a very nice article published in Lung Cancer in 2021. It's a review article, and here is established biomarkers in non-small cell lung cancer in Europe, and it was suggested that it should be tested, EGFR mutation, BRAF mutation, ALK, ROS1, and DRAG translocations, and also suggested some methods and as well as NGS. If we look for the recommendations for different guidelines like ESMO guidelines and NCCN, ASCO, Pan-Asian or international guidelines, we can see as well that we should test it a lot of molecular alteration in these cases. And it was proposed also the algorithm that the molecular analysis on tissue biopsies should have turnaround time of about 10 working days, and as well that NGS may be preferred method for the testing. The international guidelines published in 2017, at the time it was proposed 2 testing strategies. One is sequential targeted testing strategy, and another is comprehensive genomic profiling. And at that time, it was proposed 2 strategies, but it's very well seen that with sequential targeted testing strategy, it should be longer turnaround time. So the evolution of molecular testing is very rapidly, and you can see that now the next generation sequencing technologies, it has a huge impact on clinical management. So the next generation sequencing has a benefit over the traditional molecular testing methods. If we look for these traditional testing methods like immunochemistry, like FISH, PCR, they examine only pre-specified mutation in a small number of genes, fails to detect all classes of genomic alteration, and multiple tests may be needed to cover a clinically relevant genomic alterations. On the other hand, NGS-based molecular profiling tests a range of known cancers derived genes, detect multiple classes of genomic alteration in numerous genes, and cover clinical relevant genomic alterations in single tests. So you can see here the example that NGS-based comprehensive genomic profiling detects all classes of genomic alterations, and you can see this is base substitutions, for example, BRAF mutations, insertion and deletions like EGFR exon 19 deletions, copy number alterations like MET amplification or rearrangements, ALK, RET, or other translocations. So what is the benefit for NGS compared to non-NGS tests? And you can see that multiple non-NGS tests can lead to tissue exhaustions, and it can be up to 34% of these cases. And repeat biopsies to need to take to receive the diagnosis, it can be up to more than 2 biopsies additionally to receive this testing in 31% of cases. Another questions which is very important in some countries when we speak about reimbursements of this comprehensive genomic profiling, is maybe it's too expensive. But if you look for the data, you can see that molecular diagnosis is not a major cost in personalized cancer treatment, and this molecular diagnosis accounts only for 6% of the cost of molecular guided therapy per patients. And the main cost drivers in personalized medicine are anti-cancer drug and hospitalization. So why comprehensive genomic profiling? Comprehensive genomic profiling is a molecular diagnostic approach able to detect multiple classes of genomic alteration and a broad range of known cancer-related genes and match them to therapeutic options using a clinically validated platforms. Studies show that 90% of patients have potentially actionable alterations which would be targeted by at least one drug in clinical trials. So if we look for development of targeted therapies, and the majority of cancer research is now focusing on targeted therapies, and this targeted therapies is increasing, and we're now in the position of 2022, and you can see that in the next future, in the next years, it is expected a huge approval of new anti-cancer targeted therapies, and with this, the comprehensive genomic profiling will be more and more important. So next generation sequencing allows sequencing of a high number of nucleotides in a short time frame. NGS has recently moved into the clinics with the aim of sequencing long and complex genes and multiple genes per tumor sample in order to identify drivers for targetable alteration. Several companies and academic centers have implemented NGS assays to guide treatment decision. And while this technology has been widely implemented, there was no, until recently, recommendation from scientific societies about their use in daily clinical practice. And this was changed in 2020 when ESMO was published the recommendation for the use of next generation sequencing for patients with metastatic cancer. And it was proposed main questions where should NGS be used in daily practice, or can NGS substitute complex or multiple testing? If so, should large panels of genes be used? It was proposed the methodology, and recommendation for NGS was done in 3 levels from perspective of public health, of academic research centers, and level of each individual patients. It was proposed also the ESMO scale of clinical actionability of molecular targets, and it's very important for us is level 1, the match of an alteration and a drug has been validated in clinical trials and should drive treatment decision in daily practice. The main recommendation are that the ESMO recommends routine use of NGS on tumor samples in advanced non-squamous non-small cell lung cancer, prostate cancer, ovarian cancer, and cholangiocarcinoma. In these tumors, large multi-gene panels could be used if they add acceptable extra cost compared with small panels. In colon cancer, NGS should be an alternative to PCR. It is recommended to test tumor mutation burden in cervical cancer, well and moderately differentiated neuroendocrine tumors, salivary cancer, thyroid cancer, and vulval cancer. ESMO strongly recommends that clinical research centers perform multi-gene sequencing as part of their mission to accelerate cancer research and drug development through clinical trials, provide access to innovation to patients and collect data. Outside the indication mentioned before, and considering that the use of large panels of genes could lead to identification of few exceptional responders, ESMO acknowledged that a patient and doctors could decide together to order a large panel of genes. So, and as already mentioned, the most strong evidence is for advanced non-small squamous non-small cell lung cancer, and it is recommended that a tumor or plasma sample from patient with advanced non-squamous non-small cell lung cancer is profiled using NGS technology in order to detect level 1 alteration. And you can see here an example how much level 1 alteration we have in lung cancer. It's EGFR mutation, BRAF mutation, as well as MET mutation, and ALK, ROS1, and RET translocations. So this is recommendation, but how it's in real life. And 2020 it was published a REALM study, retrospective analysis of real world data to evaluate actionability of a large molecular profiling panel in solid tumors. This was retrospective multi-center French study, was conducted among 25 centers who participated in a free of charge program. And these results are that among the more than 400 analyzed patients, the most represented were lung cancer in 35%, followed by biliary tract and rare diseases. And 75% of these patients had a metastatic disease. The main results of the studies are that the priori actionability rate was 75% for all patients, and 85% and 78% in lung cancer and metastatic patients respectively. And after the exclusion of molecular only available in clinical trials, a priority actionability decreased to 62%, and in real clinical settings, the actionability rate was more than 70%. The conclusion from this round French study is that this study provides new information on the real-life actionability of Foundation-1 GCP test based on tissue samples, even if access to innovative matching moleculars can still be limited. It confirms that comprehensive genomic profiling interest in routine clinical practice, in particular for patients with advanced or metastatic disease. So, and I would like very shortly to present our clinical case. This clinical case with NGS and lung cancer treatment. It was 36-year-old patients, non-smokers. It was done surgery and lung infiltrative squamous cell carcinoma confirmed. You can see the stage of this. The operation was not radical with ER1, with high PD-L1 expression of 60%. And because the operation was not radical, the concurrent chemoradiotherapy was performed after the surgery. At the end of this treatment, the CT investigation confirmed that this disease progression with suspected local recurrence, as well as lymph nodes and metastasis in the body. The NGS was performed for this patient with Foundation-1 methodology, and you can see we found 4 alterations. One of them is EGFR exon 20 insertion, and due to this investigation, it was possibility to include the patient to special program for treatment with human bispecific EGFR and c-MET antibody amivantamab, and treatment was started and with long-lasting stabilization of the patient's conditions. So, the comprehensive genomic profiling impacts treatment decision-making, and this study shows that after NGS-based testing, about 15% of patients were found to have some alteration despite previous negative results of non-NGS testing. And based on comprehensive genomic profiling results, treatment strategy was changed in more than 44% of patients in these studies. At the time, we have 2 categories of NGS assays. One are manufactured products like Foundation-1, which have been cleared and approved by the represented authorities and are sold to clinical laboratories for subsequent use, and other are laboratory developed tests which are being designed by and deployed for clinical decision-making within a single clinical, often academic laboratories. And here are examples of different NGS assays. I think that you have experience. We have experience with Foundation One, but there are and other as well, like Illumina, Thermo Fisher, or QAGEN, and other. So the summary. Broad molecular profiling is a key component of the improvement of care of patients with cancer. And international authorities, international societies recommend routine use of NGS and tumor samples in advanced non-squamous, non-small cell lung cancer and other cancers as well. Comprehensive genomic profiling service delivers an informative molecular profile of a patient tumor that identifies genomic alteration, highlights their clinical relevance, and provides a quality controlled report to help physicians identify targeted treatment options, as well as can identify clinical relevant genomic alteration even after the other testing solutions have failed to identify molecularly guided therapy options. Thank you for your attention.
Thank you, Professor, so much for the presentation. Maybe there are some questions in the audience. Yes, I see there is one. Hello, can you hear me?
Yeah, I can hear.
Thank you very much for the presentation. It was very interesting. From your experience, what percentage of lung cancer patients currently are offered CGP and in Europe? And what dynamic do you expect to see in the next 5 years?
I can say that it's difficult to say. I don't have such information, such statistic, but it's depend on the country. Because in some countries there is availability and reimbursement of this methodology. In some countries is still no availability to do with reimbursement, only with the board of company or patients should buy itself. So it's difficult to say, but I think it's in the future because the new targets are coming and it's increasing dramatically. And of course, when we have a lot of targets and with new treatment improvement of this for these targets, it should be, I think, not so expensive to do all at once, instead to do a lot of tests separately. And this is recommendation. ESMO recommendation clearly shows that it's recommend to do comprehensive genomic profiling, and there are some cancers that is a recommendation, very strong recommendation. And I think it's the future for the targeted therapy to have comprehensive genomic profiling before the decision is made in MDT.
Thank you. Thank you. Are there any more questions? I see currently not, but if there are, please reach out to us. And again, thank you, Professor, so much for the lecture. And we also want to thank organizers for putting together such a great forum, which is so important in our day and life to improve the precision medicine access. So thank you again, and enjoy the rest of the forum.